The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to the webinar to review WHO LF MMDP data collection and reporting. Over the next hour, we will discuss the WHO LF MMDP reporting form and share examples of how information has been collected in various country contexts. Thank you for your patience as we got started this morning. My name is Whitney Goldman, and I'm with Helen Keller International. We thank you for taking the time to be with us today. We have the pleasure to hear from 4 speakers. Dr. Jonathan King from the World Health Organization, who will provide an overview of the MMDP validation and annual reporting requirements. Dr. Didier Bakajika from the WHO Expanded Special Project for Elimination of NTDs, who will discuss completion of the reporting form. Mr. Belete Mammo from RTI International, who will speak about approaches to identifying patient estimates for LF in Ethiopia. And Dr. Upendo Mwingira from the Tanzania National Lymphatic Elimination Program, who will discuss examples of identifying patient estimates in Tanzania. Before hearing from the speakers, we would like to take a moment to share a few key logistical details. You should hear the audio of the webinar through your computer speakers. If the audio on your computer is not working, you can call in using a telephone by following the instructions in the audio tab on the right-hand side of your screen. We also welcome all of your questions, which can be sent throughout the webinar using the question box. There is time set aside at the end of the webinar for all of the speakers to respond to questions. Additionally, after the webinar, attendees will receive via email a copy of the presentation and a link to a recording of this webinar. And now we are happy to begin today's presentations by welcoming our first presenter, Dr. Jonathan King.
Thank you, Whitney. Hello, everyone. My name is Jonathan King. I'm the focal point of for lymphatic filariasis elimination at the World Health Organization based in Geneva in the Department of NTDs. Next slide, please. As you know, we're all here. We've committed to eliminating lymphatic filariasis as a public health problem globally. All stakeholders are behind this. And WHO launched the global program to eliminate lymphatic filariasis, GPELF, in 2000 with 2 main aims. The first, to interrupt transmission. As you're aware, this is done through WHO recommended strategy of mass drug administration. And today what we want to focus on is the morbidity management and disability prevention to reduce suffering and improve quality of life. Next slide. The overall goal is to achieve 100% geographic coverage of the delivery of the minimum package of care that's recommended by WHO. And this is recommended through the health system at the appropriate level, integrated with other quality health services and initiatives as appropriate. WHO considers these services as to be provided under the framework of universal health coverage, part of the SDGs, with the aim to leave no one behind. Next slide, please. So what is the WHO recommended minimum package of care? It involves being able to treat acute attacks or episodes of adenolymphangitis. A patient should be able to come into a health facility that is having an acute attack and receive antibiotic treatment, to have symptomatic management, and to continue with the hygiene measures as tolerated. But a health facility should be able to provide the information needed by the patient. Next. The minimum package also includes management of lymphedema. And a health facility must be able to teach a patient how to manage the lymphedema, take care of the skin through hygiene, skin and wound care, to perform exercises, elevation, and wearing suitable shoes. Next. And finally, for those patients suffering from hydrocele, surgery is recommended for all hydrocele, and health facilities should be able to or must provide hydrocele surgery for patients. Next. As this is a part of the overall aims of GPELF, when a country has a claim to achieve requirements for interrupting transmission or the criteria for validation, which is passing the transmission assessment survey after MDA, a country also has to provide documentation that they have addressed and met the criteria for morbidity management and disability prevention. And this must be documented in a dossier along with the claim that they have achieved the global target. And in that dossier, it must be recorded the disease burden, so the estimates of the number of lymphedema and hydrocele patients by the implementation unit level. Additionally, a country must document the availability of the minimum package of care and do so as the number of facilities for the implementation units with known patients. And finally, a country must document through an assessment of a preferred assessment of at least 10% of designated facilities, the readiness and quality of the care that is being provided. Next slide. As of 2017, we can see that many countries have not reported any information on morbidity management for LF. And this is concerning because of the requirements towards validation. We know that there's a lot of global progress, in the African region towards implementing mass drug administration towards the first aim, but we're really behind globally on providing the care to those who are already affected. And there is a way to report this information and to measure this information. There are countries who are reporting to WHO the number of patients by the implementation unit and the availability of care by the implementation unit. So I've placed them here in green. But that doesn't mean that they've achieved 100% geographic coverage. This means that they are reporting as intended and are monitoring the availability of care by implementation units. And there are several countries who've reported some information, any information on the number of patients to WHO. And this is good. It means that there is data available of patients. However, it needs to be monitored now with on the implementation unit level. So it is.
This year.
Excuse me. So I think I hear. Can you mute your mic? Thank you. So this is extremely important, and in fact, it's a little unfortunate as we can't monitor the proportion of implementation units with known patients where care is being provided in 3 of the 5 LF endemic regions of WHO. So we know that there's underreporting. We feel that there is data available, and we feel there's underreporting, and that's an optimistic thought. Next slide, please. But more concerning is that if nothing is reported, there may be nothing happening. And actually, reporting data is a critical first step towards alleviating suffering due to LF, because we have to know where the patients are in order to provide the care. We we use this to identify where services are needed and to justify investments domestically through the governments and also for international donors who are interested in contributing towards morbidity management and disability prevention. And finally, as the national programs move towards achieving validation and being acknowledged for that, this information is going to be required for the validation dossier. So this is the purpose of the webinar today, is to show you how to do that and what tools are available to enable national programs to report. Thank you.
Thank you, Jonathan, for that helpful overview. The next speaker is going to be speaking on behalf of Dr. Bakajika. We have the pleasure of hearing from Dr. Denise Mupfasoni, also from WHO.
Didi is not around? Sorry. Hello?
Hi, Denise. Yes. If you can please present on behalf of DDA.
Okay.
Thank you.
Yeah. Good afternoon, everyone. I just going to present you the reporting form that we use to report the data on morbidity. As you know, WHO has a package of forms that are used to report data on treatment, but also on epidemiological data that are collected. So, next. Next, please. Yes, this joint application package, we have 4 forms. The first one is the joint request for selected preventive chemotherapy medicine. This is for drug requests. And then the second one is the joint reporting form where we report the data on treatment. Then the third one is the preventive chemotherapy epidemiological data reporting form. This is the one that we are going to present you. It's where the data on LF morbidity need to be reported. Next. So where can we find these forms? All these forms are on the WHO website. The link as it is in the presentation. And then it explains the content and the purpose of the form and how to use it. Next. So we, sorry, can we come back on the, yes, at the, on the introduction, so we have 5 sheets on this form. There is the introduction where it explains the form, what's about, and all the PC diseases is on. So if we look, we have introduction, the LF, onco, STED, and schisto. So we are going to look on the LF sheets. Next. So on the LF sheets, we have two parts of the form. On the up form, we have the morbidity management and disability prevention. The first arrow, and where we need to put all the cumulative data of the cumulative data of the patients, the number of AU with the number of patients, and we look on the last which the number of patients who receive care in the reporting year. It's the last one that changed only. So if we go to the second part of this form, We have the assessment survey in bracket mapping. It's where we will put the data that we have collected for the current year. So next. Next. So if sorry. Yeah. So then another thing that we need to know is that we need to put the number of column, the number of row required to enter epidemiological data. For example, if you have 4 districts where you have collect data, then you will put the number of row as 4 and then generate the form. When you generate the form, there is this pop-up that can ask you about new form will be generated. Then you will say yes. And then when you say yes, next, then you have five arrows where you can put your data. So we have, in the second part, we have the type of survey. It's a scroll down. You have either the survey is mapping. If you have collected data about the Sentinel site, spot check, task 1, repeat task. So this form is also used to report the data collected on tasks. So we have at the last, we have clinical care estimation. So for example, if this year you didn't do any tests, but you have collect data on patient clinical estimation, patient estimation, you can put it. But if you have collected, you have done also tasks, you can start by putting the data on tasks. And if it's in the same area, you will add also the number of patients estimated in those areas. We will see the next slide. It will be an example that has been filled by Uganda, which will show you how to fill the form. Thank you. Next. Yeah, so this is the form that Uganda sent us last week. As you see, the first part of the form, morbidity management and disability, it has been the number of IUs with non-patients, the number of IUs with non-patients. All these need to be, it's cumulative. Only the last row, number of patients who receive care in the reporting year, is the new one, is the new data that will be reported. Next. Next. Yes. So that's the form. That's the form that has been filled. This because the form is very long, we don't have all the form on these slides, but this is the second part of the form. The first part is on where we have the type of survey, when it has been done, the dates, and also the data for tasks, if we have it. Then this second part is on the lymphedema and a hydrocele. So as you see in the first arrow, it's the first IU that's where they collected data in lira. So the total number of patients and the method of patient estimation. There are many methods that can be used. It depends on the country and the fund that country has to collect, if it's a survey or if it's a recense census. They can be used as well. So there are many methods. We don't, each country can put the method that they use to collect data. And then the date of patient estimation, it helps us to see if there's no double count of year. If you put that it has been collected in December 2015 and already we have data for 2015, then we'll see that we don't have to put this data in our cumulative data. And then, so it's on lymphedema and hydrocele. Here you see that they have also put some comments. So it's good to put also comments depending on how you collect this data. Next. Okay, thank you. I'm happy to take questions on these forms filling. Thank you.
Thank you, Denise, for walking us through the reporting process, and thank you for reminding everyone about questions. You can send your questions throughout the webinar through the question box, so please feel free to do so. So transitioning now to look at some examples of how patient estimation information has been collected in various country contexts. We have the honor of welcoming Mr. Belete Mammo to share information regarding how patient estimates have been collected in Ethiopia.
Okay, thank you very much. I'm going to present you the experience of Ethiopia on the LF burden assessment. Next. So as a background information, Ethiopia has 70 endemic for the LF. And LF MMDP is one of the strategic priority in the second edition of NITD master plan, which is focusing on creating an access for hydrocele surgery as well as lymphedema management. So in order to achieve these goals, the ministry must first understand the number of patients suffering from hydrocele and lymphedema, which is very important for the planning purpose, the resource mobilization, the implementation, and the like. Next. So in order to identify patients suffering from hydrocele and lymphedema, we used two different approaches. So I will try to discuss their efficiency, accuracy, as well as cost effectiveness. In approach one, this approach is integrated with MDA activities. So the health extension workers, which were not trained clinically, completed the burden assessment tool during a house-to-house surveys linked to a standard pre-MDA census. While the second approach, it was a standalone activity. And in this approach, health extension workers reported suspected lymphedema or hydrocele cases to trained clinical officers, and the clinical officers completed the detailed the burden assessment survey. Next, please. So here I will try to discuss the process and the methods of both approaches that we used. Here it's approach one, where the health extension workers completed the burden assessment tool or the survey within their village. And this, as I mentioned earlier, this approach is integrated with MD activities, and it was conducted in 14 LF endemic districts of the Benishangul Gumuz. So initially what we did was we conducted a joint planning with the ministry as well as the Regional Health Bureau, how to integrate the burden assessment as well as the OV-LF MD activities without compromising the quality of both activities. So after we agreed on this, we integrated an extra day of LF morbidity training to a standard 2-day refresher training for OV-LF MD at a regional level. Usually the clinical health workers participated in this training. Then similarly, we cascaded this LF burden assessment training through every tier of the health system together with OV-LF MDA training. Here, the supervisors and health extension workers are participated in this cascade training. So the training is both at the regional or the TOT as well as the cascade training, focus on the morbidities or the diseases, the cause, and more of on the tool. Yeah. Then the health extension workers conducted the burden assessment during door-to-door pre-MDA registration exercise using the burden assessment tool. So while they are doing the pre-MDA, updating the pre-MDA census registers, at the same time they did the burden assessment. So they use the job aid. Those they shown each of the household head shows the household shown the job end, and based on that they collected the necessary information from the householders. So after getting the data, in order to see the effectiveness of the data collection by the health extension workers, we also validated the results by integrating the validation process with WHO post-MDA coverage survey. So as we know that the WHO post-MDA coverage survey, the sample survey builder selects only a few of sub-districts. So within those selected sub-districts, we try to validate the lymphedema and the hydrocele patients identified by the health extension workers. Next. So within this approach, the validation result of within those sub-districts or villages indicated that the health extension workers identified 170 lymphedema patients and 113 of confirmed as lymphedema, which is 97% accuracy. And again, for the hydrocele, 13 hydrocele patients reported within those villages, and 14 of them confirmed as hydrocele by the clinical health workers, which is 100% accuracy. Here, for the hydrocele, we had an additional one patient who was not present during the initial pre-MDA census, but present for the validation. Next, please. So this is the second approach. In this approach, clinical officers perform a survey of reported lymphedema and hydrocele cases. This, which was a standalone activity, and this was conducted in one of the LF endemic districts of Tigray. So under this process, the health extension workers identified households that reported the presence of person with swelling of like a hand, leg, breast, and scrotum, but did not completed the burden assessment for. Then the households, these households were visited later by trained clinical workers who validated the self-reported cases and completed the burden assessment for. Next, please. So this approach's validation result shows that 151 lymphedema patients reported by the health extension workers, and among these 79 of them confirmed as lymphedema with 52% accuracy diagnosis by the extension workers, and again 79 hydrocele patients reported by the health extension workers, and among these 22 of them confirmed by the clinical health workers with like a 28% accuracy of diagnosis by the health extension workers. Next, please. So while we are conducting the burden assessment in both regions, this following are the major inputs. The first one is training for the clinical health workers as well as health extension workers is very important in order to introduce them with the burden assessment tool. There was also a production of a burden assessment register and job aids, which include the adoption, translation, pretest, printing of the register as well as the job aid. And supervision were also very important in order to monitor the training as well as the data collection, and also to provide on-site feedback. And of course, all of these activities requires a financial consideration. Next, please. So this is a burden assessment tool that we used in both regions. On the left side, on the right side, there is a picture that shows which is job aid, which is used by the health extension workers. The first picture shows the stage of lymphedema, so that the health extension workers can easily identify the stage of lymphedema and can easily show to the head of the householders. And the hydrocele, we also included the hydrocele pictures so that they can easily shown to the head of the householders to identify the hydrocele patients. So this burden assessment included a unique ID, which is given for health extension workers, the household, and the patient, usually which is important for data entry purpose. And the information included in the burden assessment includes like the demography, the age, sex, occupation, and educational level, and also lymphedema, the presence or absence of lymphedema or hydrocele or both also included in the burden assessment tool. The severity of condition, especially for the stage of lymphedema, whether it is mild, moderate, or severe, were also included. And the episode of the acute attacks also included in this burden assessment tool. And all of this information were collected in both approaches. Next, please. So from both approaches, the finding shows that though not clinically trained health extension workers can make an accurate diagnosis of LF morbidity when they are guided by the questionnaires and job aid. And the other important finding is that the result of both approaches suggests that using clinical officers only for the initial diagnosis may tax the health system unnecessarily, because clinical health workers can more contribute to the health facility level rather than doing house-to-house survey, so that they can contribute more to the health system. The other finding is the result of approach one suggests that the dilution of quality during the cascade training is not a major concern. So as a limitation, the method of validation used in both approach 1 and 2 does not provide an estimate of the patient's missed. During the validation process, we identified that there were missed cases, but this two approach doesn't provide an estimate of these missed patients. And finally, using the pre-MDA census activities to have especially using health extension workers to collect the data is a cost-effective activity. And it is also important for the health extension workers or the community health workers to focus on other programs rather than making an independent burden assessment survey. Next, please. Thank you.
Thank you, Belete, for explaining these different approaches, the validation results, and the required inputs. We will now hear from Dr. Upendo Mwingira, who will share examples of identifying patient estimates in Tanzania. Dr. Upendo, can you hear us?
Uh-oh.
Dr. Upendo?
Hello?
Yes, wonderful. Thank you. Please.
Hello?
Yes, please go ahead.
Okay, next please. I'm going to present on examples of patient estimates in Tanzania. Tanzania is a country with a population of 55 million people. And we have endemic districts coming up to 120, while those with no LF transmission, around 65 districts. And MDA is currently going on 24 districts, while 96 districts have stopped mass drug administration. Here I present the map of NTD's endemicity in Tanzania. As you can see, we have only 24 districts where LF is endemic at the moment. Next, please. Our map before the year 2004, after completing our mapping, it was looking as on the left-hand side. Then from 2014, 2015, on the right-hand side is the one where you see there is the upper part where it's white, it is proved to be non-endemic for lymphatic filariasis. And the lower part where you see greenish and checked boxes, we find in the green areas, we have areas with ongoing MDA, and the checked lines are where LF is endemic, but the mass drug administration is not ongoing as we have stopped MDA and now doing surveillance. Next, please. Next slide, please. For patient estimation, we have been using various methods. And of recent, actually, I have to admit that we have been doing it without proper recording, but of recently, we have started putting it in more records, and we have around 4 methods which we have applied. The first one is what we have done with the support from Center for Tropical Disease. We've done it in Dar es Salaam, and we've used the SMS measure protocol, where we have mapped the disease in only one district of Dar es Salaam, the major urban city. Then we have done SMS mapping also in one district in Kilwa, and this was part of the doxycycline trial, which is conducted in that place, and we have used also the SMS. Then we have done a small study in Mtwara. We're using the Geopoll technology, and we have also been doing regional or district estimates of cases in the highest prevalent areas recently, and this is done in about 40 districts. We are expecting to use this method in the remaining part of the country. Next, please. So one by one, now coming to the SMS method, where we have done it in Dar es Salaam. This was done in 2015, and it was quite costly. It costed around 60,000 sterling pounds. And we did patient estimates by mapping through census. Community health workers and frontline health workers were the ones who were recording the data. Community health workers reported the data using paper, and then feeding it into the frontline health worker who are now who went now further to send the data to us using SMS. So it was a web-based data management process, and it needed a lot of supervision. And the training was done. The national team trained the district and the frontline health worker to use, to send the messages. And we had a great support from CNTD, though it was remotely not in the field. We have published this work in the journal and in the reference, which is shown in the slide here. Next, please. Data was collected by community drug distributors who are living within the premises of the patients, the household level, and they used papers by completing. Then they give those papers to the frontline health facility workers who are working in the nearby dispensaries or health facilities. So those frontline health facility workers are the ones who are summarizing the data and texting the data in that format, which is shown in this text box. So the program, after training, we were not involved in the collecting data, but we just conducted clinical validation and follow-up to validate at least 10% of the cases which were reported by the frontline health workers. Next, please. So the guide which we gave to the health facility, to the health workers, to make sure that they know the case. So we gave them a paper which talks about the stages. How does it look? It's coastal soiling. How does it, kind of a definition, small definition, and then whether they have acute attacks, age which was reported, the severity. So all those parameters or variables which were reported in SMS, we tried our best to explain to the health workers so that they understand, so that they can easily fill the forms and then transmit those forms to the frontline health workers. So this is just a health facility worker guide. Next slide. The results from this study, as it's shown in this slide, Dar es Salaam had by then 3 implementation units, or we call councils, municipal councils. So the results from that study indicated that this number of patients recorded, we had a total of 2,251 lymphedema patients, and then 4,169 hydrocele patients, and those with bilateral, both pathologies were 469. And you could see from the same results in the map presented, there are areas where you see concentrated number of patients down there, all cases. Then hydrocele, most of hydrocele were in the southern part of Dar es Salaam. And then for lymphedema, you also see the northern part of Dar es Salaam. So in general, the results indicated that there are many patients, more than we expected. So in total, around 6,889 patients were identified during this survey. Next, please. In the second method, second study which we did using SMS as well, this we had a ride of the ongoing Ledoxy trial, which is a multi-country study. So we used unstructured supplementary service data, and the study costed us around $20,000 US. This time we used our in-country saver, and we used community drug distributors as well, who reported the data back to us by following a drop-down menu, which we gave them, and they filled in the data. Next, please. Prior to the results, the community health workers transmitted the data to the frontline health workers the same way as it used to the Dar es Salaam study, and thereafter we compiled the data at the district level and came out with the following results. All wards were visited. Kilwa has 99 wards, and all of them were visited, and all of the villages were visited. And the results indicated that males registered were 1,906, while female were 1,893. And out of them, 1,145 patients were identified to have scrotal swelling or hydrocele, and 361 to have lymphedema. Those with mixed both pathologies were 54. We have not yet validated this. Verified the cases, and it's currently ongoing. As I said, we took the ride of the ongoing study, so we didn't have separate funding for the work. So the validation is ongoing now, while the Luxis trial is ongoing. But so far, the validation is around, for the patients who have been seen for the validation through the Lodopsy trial, is around 90%. Next, please. The third survey which we have done is the Geopoll. We had a rationale of estimating the prevalence of lymphedema and hydrocele patient in the municipal council of Mtwara using the mobile phone-based survey, the Geopoll. And it was a cross-sectional survey which was conducted among adults who were accessing mobile phones in that specific region. It was not that much expensive, but it required $10,000 for the work. Next, please. So, as you could see, those with phones are many in Mtwara. So everyone, actually around 859 people received the text messages for our study. But majority of them did not respond. They opted not to fill in the questionnaire. Those who opted were 1,330, and out of them, a lot, also around 700 people, did not finish the survey. 482 were the only ones who finished, completed the survey. And out of them, it was a self-reporting, first of all, I have to say, this was a self-reporting. And then out of them, 103 had reported to have lymphedema, while 101 reported to have lymphedema, and those with both were 288. So this is just a chart of what came out of the study. And hydrocele patients were 59.5%, and 46 of them had lymphedema. I think you can see from the chart which we have presented. And there are some who reported for this patients, I mean, their friends or relatives. So it was self-reporting, but you could also present or say about whether you have seen someone nearby, your relative or your friend. So that was also recorded, and 66% said that their relatives had lymphedema, while around 70.9% said their family or friends had hydrocele. Next slide. The fourth method, which is long, what we've been using for a long time, but now we're still putting records on it, is the regional coordination of activity of district estimates. That means the region or district, they get information from the district after filling the questionnaire of how many patients, or they ask through the health facility or through the information from the communities, and we get that information through the regional secretariat. So the rationale is also to estimate, get the burden of the lymphedema and hydrocele, and we've used this recently as well, so as we can get estimates to enable us better planning and prioritize our resources for hydrocele, hydrocelectomies, and also lymphedema management. So this is managed patients estimates methods, varied CDDs estimates during MDA, also the community health workers during their census, when they are doing census prior to MDA, using their own funds, or wherever possible, whenever these community drug distributors, they have this information, maybe just because they live near them. So the most reliable informant here is the community drug distributor. And from there, the data is compiled and cascaded down upwards from the community level to the health facility, and coming up to the district and region, and then up to the national level. Next slide. So we have, from this method, we've been receiving reports, and around 44 districts in the 5 most endemic regions have already reported. And from their data, we see that we have a total of 2,945 lymphedema reported cases, and also 5,816 hydrocele cases. So this data is already put in our dossier document, in our reporting form, and we are expecting to have this method being applied in the remaining of the districts. Next, please. So I have to admit that we have been experiencing some challenges to get this information, and we also have the benefits of getting this information. So for the first one, where we've done it which we have done in Dar es Salaam, you get the information very fast. It's a web-based data. It enables real-time supervision. You could clearly see, oh, there's something wrong here. You just call back the frontline health facility worker to improve the data and the quality of data. But as you could see, it was 60,000 pounds. It was very costly. For the one we've done in Kilwa, we have used the other platform, the Rodoxy trial. So you ride on, so it's not very much cost. Even the cost I've mentioned, it was not bared by the program. But as you can see, there was delays, and there's still delay in verification. And also the cost, sometimes if we do it ourselves, we find it's also costly to do it as a standalone activity. For the Geopoll, we have quick results. It was quite reasonably, if everyone filled the information, we could say it was cost effective. But there was a challenge that it was a self-reporting. There's a need also for verification to make sure that what they've reported is exactly lymphedema or hydrocele. And for the one which we've done for district estimation or regional district estimation, the budget is embedded within the activity. So it's not bared directly by the program. They can do it any time of the year. You don't need a separate, it could be during the MDA, it could be during any other activity. But it also needs case verification so that we can make sure that what you're talking about is exactly the same. The case defined is exactly the same. Next, please. I would like to acknowledge the patients, the district coordinators for supporting us. It has been very useful, and I say this is what we are planning to do in the remaining of the districts. And we are thanking the supporting partners, as I've listed them here in my slide. Thank you very much for listening.
Thank you, Dr. Upendo, for talking us through these various approaches that were implemented in Tanzania. I'd like to once again thank all of the presenters and would invite those of you participating in the webinar to please submit your questions you may have of any of the presentations via the question box. I think we're going to take just a few minutes to ask a few questions, and we will be circulating a document with all questions and their responses following the webinar. So our first question has come through, and it's for Jonathan. If there are questions or if national programs encounter difficulties when completing the form, who should they contact?
Thanks for the question. The best place to contact is to go to your WHO country office, where there should be an individual that is responsible for NTDs. This is normally a national professional officer. If one is not available in the country, of course, you could email the question directly to them, and it always helps if you can copy the regional office as well. So the focal person would be DDA. And so we can provide email addresses for DDA and also even at HQ level. But it's best when a national program, when trying to fill out the form, has that interaction with the WHO country office.
Great, thank you, Jonathan. I think we have time for maybe one more quick question. Belete, it's to you on your presentation from what's been conducted in Ethiopia. The question is, what other conditions were identified by the health extension workers that were confused with lymphedema or hydrocele?
Especially for the hydrocele, they just registered self-reporting by the head of the households or by the patients themselves. So during the validation as well as during hydrocele pre-screening activities, we identified that in addition to hydrocele, the health extension workers registered tumor, scrotal tumor, scrotal lymphedema, and a number of hernia were registered by the health extension workers. For the lymphedema, actually most of the endemic areas are also quite endemic for podoconiosis. So for the just after the head of the households or the patients after they report, they just observed and make staging. There is no as such problem for lymphedema, but in some areas like in Tigray, there were also like leprosy were also recorded by the health extension workers.
Thank you, Belete. So on that note, we've arrived at the end of the webinar. I'd like to once again thank the presenters, Jonathan King, Denise Mupfasoni, Belete Mammo, and Upendo Mwingira. We'd also like to thank all of you for listening in and asking questions. So a recording of today's session, copies of the presentation, and a question and answers document will be shared a few days after the webinar. We would also greatly appreciate you taking a brief moment to provide feedback following today's webinar through a short auto-generated survey that will display in just a moment. We'd also like to remind you that there is a French webinar that is scheduled for tomorrow at the same time. It will provide a similar overview from our colleagues at WHO, but we'll provide two additional country examples from Burkina Faso and Cameroon. So with a final thank you, we appreciate everyone joining us today, and we will conclude this webinar.